Okay, home stretch for Hemonc for the morning. One thing I was going to point out, a couple of people grabbed me during the break, pointed out something that I think is worth clarifying. Iron deficiency in babies less than 12 months. I sort of indicated I think it's rare in infants less than 12 months. Again, not to say that it doesn't happen. I guess my point is, if parents are doing the usual feeding practices of whether it's breast milk, iron fortified formula, even if they're purely breastfed, they should be introducing iron fortified cereal, baby foods, things of that nature. I guess my point is, if a baby from age 0 to 12 months eats and drinks the usual things during that first year of life, we just don't see iron deficiency all that much in infants. Preemies accepted also. Someone brought up they're definitely at risk for low iron anemia. So anyway, just wanted to clarify that in case anybody else had noticed the same thing. All right, so let's do some questions. Ready? I hope everything that you see here you've heard at some point this morning, either from me or from Dr. Flagg, so let's go. So neuroblastoma first. Which of the following neuroblastoma features is not prognostic for survival? You've heard a lot about risk stratification strategies this morning. Which of these is not prognostic for survival? Okay, excellent. So the answer is, in fact, D. We had a few who thought NMIC. Okay, that's most definitely prognostic. It's bad. You do not want to be NMIC amplified. And stage for sure, right? Because if you're stage 1, 2, or 3, those kids do very well. If you're a stage 4S, very well. If you're a stage 4, those kids do very poorly, okay? Calcifications on CT scan, of course, that's a good way when you look at a first CT scan and you're deciding, is it a Wilms? Is it a neuroblastoma? Can I see the adrenal? What do I think this is? A neuroblastoma is more likely to contain calcifications in it. So we're guessing people when we look at scans, but it doesn't matter if your neuroblastoma has calcifications in it or not. It is just a finding on imaging. Okay, in which of the following tumors is long-term control most likely to be achieved with currently available treatments? You have 4 different stage 4 choices. Who's going to do the best? Ooh. So the C's have it for sure. Okay, if you take nothing away from here, stage 4 neuroblastoma is horrid, okay? It's terrible. Stage 4 rhabdo, very bad, probably, maybe even worse than stage 4 neuroblastoma. Hodgkin's, very curable. Even the advanced stage patients, very curable. As Dr. Flagg alluded to, we're getting so good at curing Hodgkin's that we're trying very hard to figure out who can still have excellent long-term survival with fewer toxicities, because we are creating a lot of sort of what we call long-term late effects with those patients. Stage 4 osteo, they probably have long-term survival 40 to 50%. Okay, how about generalized lymphadenopathy? Is a common presenting sign in which of the following groups of childhood malignancy? Generalized lymphadenopathy. Excellent job. C is the answer, yep. In any of these other combo platters, just less likely to have that show up. Certainly B, when you have osteosarcomas, any sarcomas and a Wilms tumor, you wouldn't see adenopathy. In A, for sure, neuroblastoma and ALL you would, not with a rhabdo. AML, yes, neuroblastoma, certainly if they present an advanced stage, but not a hepatoblastoma. And with E, certainly not with a Wilms or a retinoblastoma would you expect to see generalized lymph nodes. Okay. 4-year-old African-American little guy taking some trimethoprim sulfamethoxazole for an acute sinus infection. He develops fatigue, dark urine, and pallor. his most likely diagnosis is what? Okay, great. G6PD, right? The couple of clues in that one are that this is a male patient, right? This is an X-linked problem. And he has ingested a drug well known to be an oxidant stressor to these red blood cells, and that is Bactrim. Okay? You can see G6PD in girls, by the way. It is notable. I've seen it. It's landed in my lap easily a couple of times. Had a girl who had been over in her home country and had actually ingested a bunch of fava beans while she was over there, tanked her hemoglobin to about 3 or 4. So it does happen, okay? So not only in boys. So in the proper clinical context, you should be thinking of G6PD if the story fits. Okay, what do we have here? A 3-day period. Petechiae developing over the trunk and extremities of a previously healthy 5-year-old. He's been bruising easily for about a week. He has had no fever. CBC reveals a white count of 10.5 with what looks like a decent differential. Hemoglobin 13, MCV 87. Platelets are 10,000. What is his most likely diagnosis? Interesting. Okay. So I'm going to say the answer here is with the B's, okay? ITP. I would argue that this is not a great story for HSP. Where did I put the bruising? Trunk and extremities. I suppose that's usually extremities, buttocks. Afebrile. We didn't hear anything about abdominal pain. Meningococcemia, Rocky Mountain spotted fever. That child should be febrile and more ill-appearing, right? And ALL, that's a pretty good-looking CBC for someone to have ALL. They would unlikely present with just isolated severe thrombocytopenia. Okay, all right. Okay, 3-year-old girl, hemoglobin 9.8 when she came to your clinic 3 months ago. Her MCV at that time was 68. She had an RDW of 11%, which is normal. Elevated is over 15% about. Red blood cells, 5.1. She was placed on oral iron at a pretty good dose, 5 per kilo per day. On her return visit, 2 months later, her retics, 1.8, indices unchanged. Her peripheral smear looks like a bunch of small hypochromic red cells. What do you think these data fit with? Good. All right, so the answer here is A. So this is classic for thalassemia trait, right? You can't tell if it's alpha or beta, but a mild degree of anemia with a disproportionately low MCV, normal RDW, because all of the cells that she's making are small, but they're all the exact same size, okay? And her RBC number is actually elevated, okay? An RBC number of 5.1, that's a little bit high. Get used to looking for that on CBCs, because if you have somebody who's iron deficient, that's a production problem, and their RBC number should be low. So if you have something like this and you think, oh, I think she has iron deficiency, well, if you don't have enough substrate, how are you making that many red blood cells, right? Sickle cell trait, those patients should actually have a rock-solid normal CBC if you have sickle cell trait alone. This would be an awfully good hemoglobin for someone, a couple of things. For someone with sickle cell disease, this would be a very generous hemoglobin. They shouldn't have an MCV quite that low. The only sickle, I would say the only hemoglobinopathy that could fit here would maybe be S-beta thal plus, right? Because they'd have a decent hemoglobin, but a lot of microcytosis. And folate deficiency, of course, you would have an elevated MCV, okay? All right, how about jaundice developing in a healthy Caucasian 7-year-old girl? Physical exam does reveal some splenomegaly. CBC, she has a white count that's normal, platelets that are normal. Hemoglobin, a little low with a normal MCV of 85, and her retics, nicely a little bit brisk at 6%. Her most likely diagnosis is what? Okay, good. If you're a betting person and you have a Caucasian girl who is hemolyzing, certainly at this age, go with hereditary spherocytosis, okay? You wouldn't pick G6PD because it's a female patient. Pyruvate kinase is just exceedingly rare. I don't think I've ever seen it. And ALL, you certainly wouldn't expect with a CBC that looks this good, okay? Highly, highly, highly unusual, not unheard of, to have a new diagnosis of acute leukemia with a normal platelet count. Think of a normal platelet count as actually a very good sign of a healthy bone marrow. You know, a bad bone marrow can't make a good platelet count, generally speaking. So always get in the habit of looking at that. Okay, Dr. Flagg talked a little bit about tumor lysis syndrome. Pick for me the set of labs that looks like it. Okay, the D's have it. All right, so why doesn't A fit, right? Because you develop hypocalcemia with tumor lysis syndrome, so A doesn't fit. B is out because hyperkalemia is always the big feature. And C is out because uric acid actually goes up when you're in tumor lysis syndrome, okay? So the strategies that we employ to avoid it or fix it are getting potassium out of the system with potassium binders, pulling phosphorus off. That's actually the most common reason that someone who has tumor lysis needs to be dialyzed is because they have hyperphosphatemia. Supplementing them with calcium, simple things like Tums, and putting them on medications like allopurinol to solubilize the uric acid so that they can lose it in their urine, okay? Okay, 4-year-old boy comes to your office. What do we have? 3-day history of fever, 101 to 102. Some decreased oral intake, let's say non-specific complaints of abdominal pain. Physical exam reveals scattered cervical lymphadenopathy, several bruises, and a palpable spleen tip. Which of the following seems to you the least likely? I get people all over this one every time. So the one I go with on this one is strep throat. I just feel like as the least likely. If you put everything together, so fine, you could have fever, abdominal pain, and some nodes. I'm not sure you can justify a spleen tip with strep throat. I think all of the others are a better fit for this boy's, just what you know about him so far. Okay, I don't think you'd be able to work a spleen tip in with strep throat. Now, let's say you're suspicious enough on your physical exam, right? You grab a CBC. He has leukopenia with what looks like a little bit of a deranged differential with only 8% neutrophils. Hemoglobin 7.9 with a normal MCV and platelets of 76. So you went after mono. Your mono spot in the office is negative. Now what do you think he has? Okay, good. So the majority gets it. So this really sounds an awful lot like a new ALL or AML patient, okay? So aplastic anemia, not great for a couple of reasons, right? His MCV is normal, and typically in a bone marrow failure syndrome, you'll have an elevated MCV, okay? The other thing is he had lymphadenopathy and splenomegaly on his exam. Remember, we talked about aplastic anemia. That is just nobody home in the bone marrow. It's not an infiltrative process the way acute leukemia is. So generally speaking, with aplastic anemia, they have a pretty darn good looking physical exam, often other than skin findings of low platelets, maybe pallor because they have anemia. They shouldn't have nodes, shouldn't have a spleen tip. ITP, not with a white count of 1.2 and a hemoglobin of 7.9. And mono, I would argue, same story. Okay, good. All right, back to another one of Dr. Flagg's talks. Hemihypertrophy and aniridia are associated with what? Excellent. Wilms tumor, right? So these patients who have hemihypertrophy, well, I think they've renamed hemihypertrophy, right? And I can't even think of what they call it now. But we screen aniridia, as in Wagner syndrome, right? Wilms tumor, aniridia, GU abnormalities, mental retardation. We screen these kids for hepatoblastoma and Wilms tumor. Okay? Okay, another one, Beckwith-Wiedemann syndrome, associated with which of the following malignancies in children? Great, great, great. Tricked a few of you. Adrenal tumors, true statement, along with the Wilms and the hepatoblastoma, but these kids are not at risk for Hodgkin's, okay? Okay, 23-month-old boy, what do we have here? 2-week history of progressive cerebellar ataxia. You think, uh-oh, this kid's a new medulla, right? So an MRI of the brain is normal, good for him. What other type of malignancy should you be thinking of? Great, good job. So this is part of the opsoclonus myoclonus ataxia syndrome, right? And what's behind this is there are antigens on the neuroblastoma cells that look like cerebellar antigens. And so this person's immune system is actually just sort of an autoimmune phenomenon directed at the cerebellum, which is causing them to experience some ataxia. It's actually good because this brings these patients to medical attention earlier. So they actually are often diagnosed with lower stage disease, which, as we've learned, is a huge thing for neuroblastoma. Okay, how about proptosis as a presenting sign is more commonly seen in which of the following pediatric tumors? Yep, I get people on this one too. So retinoblastoma is an intraocular tumor. So unless you're practicing on a regular basis in an underdeveloped or undeveloped country, you won't see retinoblastoma presenting with proptosis, okay? But an orbital rhabdo, which is one of the more common and actually favorable sites where we can see a rhabdo, they will absolutely present with a little bit of proptosis, okay? Okay, coordination difficulties can be a presenting sign in which one of the following tumors? Good, good, good. Okay, so osteo-Hodgkin's or a primary temporal bone Ewing's, wouldn't expect that. And I think Dr. Flagg pointed out, so CNS leukemia at diagnosis. It's actually usually asymptomatic, and we just find it on their diagnostic LP. If it's going to present with anything, it's often a cranial nerve palsy. And certainly supratentorial brain tumors that we see a little more often in older school-age teenage patients than the infratentorial medullos and such. They will present of headache, seizure activity, things of that nature, okay? All right. 15-year-old boy has difficulty breathing when he lays flat in his bed. When he sits up, everything seems to feel better. What might you expect to find on his physical exam? Okay, majority of you got this, all right? So this sounds a little concerning for something hanging out in his chest, right? I think Dr. Flagg has shown you at least one x-ray that looks similar. Is that what I have next here? Okay. So this is his chest x-ray. Okay. Real patient of mine, actually, last June. What is his most likely diagnosis? Good. Okay. Huge mediastinal mass, right? And if you're a betting person in a 15-year-old, all bets on Hodgkin's, no doubt about it, okay? ALL, pre-B immunophenotype, I would say if we ever do have a mediastinal mass in an acute leukemia patient, it's more likely to be T-cell hanging out in the chest, okay? The B-cell lymphomas tend to hang out in the abdomen. You can remember that. T in the chest, right? B in the abdomen. Wilms tumor metastasis, neuroblastoma certainly wouldn't look like those, and sarcoid is just odd, okay? Okay. Ooh, and that's right, I added these. So real patient, right, from last June. So you never know how bad these kids are when they lay flat. I think, did I put in a few serial images here? So there's his trachea that you can already see is not midline, right? So already there's an issue. It's being pushed over to his right. And then a few slices we go down. He's got this huge mediastinal mass in the anterior area there. But here goes his, so can I point it out? This is his carina that's about not quite 2 millimeters open when he lays down. And I think this is his left main stem that is completely crushed, and his right main stem that came out the other side. Okay? Pretty impressive. And that kid had actually technically stage 2A with bulk Hodgkin's, and he's doing well now. Okay, 10-year-old African-American boy admitted to the hospital. So sorry, I should back up. So Dr. Flagg gave you a question about what do you not want to do with that person. Okay, that is not a kid who should go to the OR for a Metaport placement, for instance. Shouldn't even go to the OR for a biopsy. Because when that kid gets general anesthesia, that trachea is going to collapse, okay? And even if you've intubated those patients, if that obstruction is below the ET tube, they're in big trouble, okay? And those are patients who may not survive their trip to the OR, okay? Oh, sorry, we started your timer over here. Okay, 10-year-old African-American boy admitted to the hospital, bilateral leg pain, no fever. Hemoglobin 8.1 with a lowish MCV. Bilirubin a little elevated, 2.6, with retics that are nicely elevated at 8.4%. What do you think would be unlikely on his smear? Good. Sounds like a little kiddo with sickle cell, probably, right? Coming in with a vaso-occlusive episode involving his legs. Definitely, you see target cells in the periphery in kids with hemoglobin S, hemoglobin C, the thalassemias will also display some target cells in their periphery. Hollow jolly bodies, right? Those are an indication of functional or anatomic asplenia, right? He's 10 years old, so we presume he has no splenic function. And sickled cells, I think you'd expect. Okay, now I think next question sticks with this little guy. Which of the following would be least important in managing the above patient's vaso-occlusive episode? Least important. Okay, good. So no mention of fever in this kiddo, right? No mention of fever, so antibiotics aren't indicated for him. The cornerstones of managing a vaso-occlusive episode, fluids, okay, so you can get those red cells hydrated again and unsickled, anti-inflammatories, whether it's oral Motrin, IV ketorolac, and narcotic analgesia, whether they're doing it at home with oxycodone, oral morphine, or whether they're in the hospital getting IV narcotics, okay? Good. Okay, what is this one? A well-appearing, well-nourished, asymptomatic 2-year-old has a large right-sided abdominal mass. You order an ultrasound, confirms a large mass appearing to arise from the right kidney. Which of the following radiographic studies is not indicated? This one gets people all over a little bit too. All right, the correct answer for this one is B. So it sounds like a Wilms tumor, right? So it needs to be staged, needs better imaging, first of all, than just an ultrasound. So CT, chest, abdomen, pelvis, and your chest will search for metastasis. Chest x-ray does the same. Ultrasound of the IVC, right? Because the right-sided Wilms tumors, the big ones, they can sneak right into the IVC, travel all the way up and right down into the right atrium. Okay, so for right-sided tumors, we need to do that. No indication here that this looks like a paraspinous neuroblastoma. If you thought that that's what you found, then you would want an MRI of the thoracic, lumbar, and sacral spine. All right, how about a 5-year-old girl with neurofibromatosis being evaluated for progressive visual difficulties and headaches? She should be evaluated for which of the following tumors? Okay, so this one is optic glioma. So remember this one. This one will show up on boards, and this is simple. Right, Dr. Flagg said, almost unheard of to see a patient with an optic glioma who doesn't have NF, okay? So if you ever see neurofibromatosis on a test and they want to know what kind of tumor, it's an optic glioma, okay? And then you remember the tuberous sclerosis kiddos. You look for the SEGAs in those kids, right? The subependymal giant cell astrocytomas. Okay. So here we have a patient diagnosed with ITP, right, or our new name, immune thrombocytopenia. Which of the following are the most common initial treatments used? So first-time treatment. Okay, fooled some of you. So F is correct. Why? Because we don't do splenectomy up front. Okay, splenectomy is reserved for select chronic ITP patients, but steroids, anti-D, IVIG can all be upfront treatments. Okay, here we are at the end again. We're cruising right along. Okay, so now we're going to match chemotherapy with most common toxicity. And I'm going to be careful not to hit my button because I've done this before and it shows you all the answers. Okay, so the first one, number 23, is cisplatin. So choose from the right. What do we worry the most about with cisplatin from a toxicity perspective? Okay, good. F is most definitely the answer. So with cisplatin, we do worry about nephrotoxicity. They can develop sort of leaky Fanconi type kidneys. They end up needing a lot of electrolyte supplementation, but certainly we don't worry about anything hemorrhagic in that regard. But definitely ototoxicity, it's a big issue for littler kids with hepatoblastoma, brain tumors who get a fair amount of platinum at a very young age. They can end up with some pretty significant hearing loss that even at higher frequencies is a problem for them when they haven't experienced all their language development yet. Okay? Good. Next is vincristine. What's the favorite one on the right side? Great. Absolutely, neurotoxicity. So vincristine is it's a neurotubule inhibitor, right? So a lot of the toxicities we see have to do with just that. We see some peripheral neuropathy, whether it's in the fingers and toes. We see kids who, these kids with ALL, for instance, who get a lot of it, they'll develop a foot drop, they'll start toe walking, and we need to address that with physical therapy. I had a little, 3-year-old with ALL, and he told his parents recently, I thought this was a great description, he said his fingers felt like they were a cactus, which I thought was an apt description. Teenagers who get a lot of vincristine for their Hodgkin's, they'll develop some peripheral neuropathy. Constipation, really big one too, right? Because the nerves that innervate the bowels get very lazy with vincristine. Okay, good. Number 25, bleomycin. Commonly used with Hodgkin's and the germ cell tumors. Okay, good. Pulmonary toxicity is what we really watch out for with bleomycin. It is a dose-dependent phenomenon. We watch pulmonary function tests with these kiddos over time. And some of them do develop a little bit of restrictive lung disease, thankfully more often than not to the degree that it affects quality of life, but we do monitor for it. Okay, good. Asparaginase. Great. Pancreatitis, and I don't mean mild pancreatitis. This sometimes is fatal to these kids. They can have hemorrhagic necrotizing pancreatitis that actually causes them to die from an acute toxicity. So we are very mindful to watch for complaints of abdominal pain. So let's see, if you see a board question and it's a leukemia patient who recently got some asparaginase and they're in the ER complaining of abdominal pain, this is what you better think of, okay? Because if you miss it, this kid could suffer a fatal event. We will actually withdraw asparaginase therapy for a significant pancreatitis event. It can be very dangerous, okay? Okay, number 27, cyclophosphamide, used ubiquitously in our kids. Now they're getting easy because we only have 2 left. Right, this is the hemorrhagic cystitis one, right? So these kids need a lot of IV fluid to keep their kidneys and their bladder flushed out. They get Mesna as a uroprotective agent. That's easy. And then the doxorubicin, last one, super easy. I better get 100% up here. The pinkish orangish chemo that the parents always recognize. In the anthracycline group of medications. Yep, thank you. Yay! Can get bad, so dose-dependent cardiotoxicity. Sometimes it's a dose-limiting toxicity for sure, and at times has significant long-term effects, especially if people have had to have radiation to their chest that will also affect their cardiac function. Can turn into an issue for women who are survivors of childhood cancer because they'll turn into a high-risk pregnancy. If they have a little bit of diminished cardiac function, their blood volume, gosh, what is it, double or triple during pregnancy, and if they just can't manage that cardiac output, it turns into an issue. So, good, so I think that's all, thank you.